Good afternoon, everyone. This is a Health and the Public Interest MS Programs weekly seminar series. As we move toward the end of the semester this year, we're going to go till we have two more seminars after this one, just because of how the academic calendar lays out, and then we'll be resuming after relatively early in January. So glad to have you all with us today. We have a new instructor in our program, Donell Harvin, who's going to be speaking. He'll be introduced by Sasha Mohan. Um, I'd like to just say a couple words about how the seminar will run. It's the same as always. Dr. Harvin will speak for around 40 or 45 minutes, and then we'll have ample time for question and answer. Sasha's going to do the introduction, and then she will moderate questions first by our students and then by other guests. And with that, I will turn it over to Sasha.
Thank you, Dr. Myers, and hello to everyone who has taken time out of their week to join this week's HAPI seminar. My name is Sasha Mohan, just like Dr. Myers just said. I have the absolute pleasure of introducing this week's HAPI seminar speaker, Dr. Harvin. Dr. Donell Harvin is a Homeland Security and Public Health emergency subject matter expert and serves as faculty in Georgetown University's Emergency and Disaster Management Master's Program and the Applied Intelligence Master's Program within the School of Continuing Studies, and teaches terrorism studies in the Walsh School of Foreign Services and Public Health in the Master of Science in Health and the Public Interest Program. Concurrently, he has been appointed as a visiting scientist at the Harvard School of Public Health, where he oversees the Harvard Humanitarian Initiative, Chemical, Biological, Radiological, Nuclear, and Explosive Research and Training Program, focusing on disaster-related capacity building activities within Ukraine. He is a Homeland Security analyst for MSNBC and NBC and Politico, where he provides commentary on a wide range of issues, including domestic extremism and terrorism, mass attacks, and intelligence. Additionally, he serves as a subject matter expert for several international organizations, including the United Nations Office of Counterterrorism, Interpol Counterterrorism Directorate, the Naval Postgraduate School, and Center for Homeland Security Executive Education Program, where he conducts executive level seminars in emergency management, terrorism, and threat mitigation. Dr. Harvin's public safety career spans over 30 years and includes executive roles in fire and EMS, law enforcement and forensic, countering WMDs, Homeland Security, and intelligence. He is the former Chief of Homeland Security and Intelligence for the government of the District of Columbia, where he oversaw the National Capital Region Threat Intelligence Center, DC's Fusion Intelligence Center. As the executive director of the Fusion Center, he oversaw the district's operational intelligence and response to the insurrection at the U.S. Capitol on January 6, 2021. As a result, he testified in front of the House Select Committee for January 6th, where his testimony was aired publicly during the televised hearings. Throughout his operational career, he has been involved in major incidents, including 9/11 as a member of FDNY, the Sandy Hook school shooting, the January 6th attack on the U.S. Capitol, and most recently, WMD disaster-related capacity building activities within Ukraine. Dr. Harvin holds an undergraduate degree in Fire and Emergency Services Management, graduate degrees in Emergency Management, Terrorism Studies, and Environmental Science, and is a Doctor of Public Health, specializing in environmental epidemiology and public health disasters. For his dissertation, he was appointed as a research fellow at the Mason Lab of Cornell University School of Medicine, where he conducted experiments, gathered data, and performed shotgun DNA sequencing of pathogens that he had sampled from emergency response vehicles across the country. His research goal was to establish the baseline microbiome of the environment that first responders work in and gain insight into potential exposure pathways for pathogens that may be introduced into emergency response vehicles. So without further ado, Dr. Harvin, you have the floor.
Thank you, Sasha. I didn't think you'd stop. Um, Thank you for the invitation, Adam and Adrian. It's really a pleasure for me to be here. Let's just jump into it. I got into public health because of 9/11. I was a first responder for many years, was very happy doing that. I worked for FDNY. And then one day on September 11th, the world changed. And along with the world, my perspectives on health and safety and public health also changed. And so I'm going to take you through a responder's POV of 9/11. This photo was actually taken on 9/12. It wasn't taken, 3 or 4 weeks later. I was there for both tower collapses. I was there. I got there just after the second plane had hit. Um, and I spent the night at the site. And then the next day, I actually rummaged through a CVS and got a disposable camera. We didn't have cell phones back then. Some of you who are longer in the tooth would know that. We had cell phones, but we didn't have cameras, right? So we had these little flip phones. And I got one of those, disposable, paper, cameras that you would drop off at the pharmacy and get a few days later, you would get your photos. And the reason why I did that wasn't to take selfies. So I want to be painstakingly clear. It was because I also taught at the academy. I've been teaching for a while, and I know my students at the academy weren't there, and I wanted to capture some images of what we were going through to share with them, and I wound up doing that. I produced these on many of you may know the little carousel slides. That you would project onto a screen. That's how old this stuff is. And I had it in that form for many, many years, for at least a decade. And I do, and then when we got PowerPoint, I would still roll out this carousel slide because that's how I had these things. And so at some point, one of my students who was a little more technologically savvy said, you should digitalize those and put them in a real PowerPoint. And this is what I did. The quality is poor, so forgive me. And once again, this was never intended to kind of do selfies. I am one of the very few first responders who were fortunate enough to have a camera and captured what we found. And many of my photos are at the 9/11 museum in their archive. And so this is me. Once again, I wanted to stand there for scale to show the kind of enormity of the disaster on September 12th. Um, this is any New Yorkers here in the class on the audience and know New York. This is the firehouse that's just across the street. Literally, is a firehouse across the street from the World Trade Center. They were the first to respond, and none of them came back. We wound up essentially taking over the firehouse and turning it into an emergency medical station for first responders. A lot of what you see were eye injuries, extremity injuries, and a lot of that was from being caught in the collapse or kind of digging for family for we call them family, but for their coworkers. This photo on the right is a one I always like to show. This gentleman on the right with the bicycle with the motorcycle helmet, his name is Donell Ford. He basically didn't go to the station. He just drove straight there. That's why he doesn't have his official helmet and kept his bike helmet on. He actually died 2 years ago from an aggressive form of liver and pancreatic cancer. And the physicians told him that the type of cancer he had was really basically reserved for those people who abuse themselves over the course of their life with drugs or alcohol. And the unique thing about Donell Ford is that he was Muslim, he didn't drink, and he didn't smoke. So just kind of give you an anecdotal context about, and he was a karate instructor, right? Really fit guy, took care of his body, but 9/11 laid low many, many healthy people. Um, and the reason for that is because there was really little to no, I would just say no, on-scene occupational health and safety presence. And so you can see if any of you, want to go into occupational health and safety or environmental science, I'm more than happy to speak with you offline. This is the reason why I started studying public health. It's because so many people that I know started getting sick and dying and I got sick myself. And if you can, if you're trained eye in terms of occupational health and safety, you can see a multitude of violations here. And so we'll talk a little bit more about those in depth as we go. And Sasha, if you could just keep me honest with the time and just give me like a 20-minute left kind of heads up. I actually am in the class that I teach. I have a class that starts at 1, so I'll be able to go to about 12:40 and take questions for about 15 minutes before my class comes in. Um, Once again, I'm scared of heights, and this disposable camera doesn't really give the image. But this is the infamous pit that you may have heard of. This is about 10 stories deep. This is over 140 stories deep. And I just kind of held the camera out and went like that because I don't like heights. Just to show the conditions that these rescuers were working in, very little protection in terms of fall protection, oversight, very dangerous, and many people did get hurt on secondarily to the disaster, just from the disaster operation. In terms of lack of oversight, we also had civilians. All the construction sites shut down, and they sent their metal workers down to us to help cut the metal. So they brought their equipment and things. And if you know about construction sites, it's really highly regulated by OSHA, and the operations like this would be highly regulated if it was a construction site. But disaster sites are completely different. You may see a couple of photos where we're just kind of sitting around, um, mulling around. Um, that was not unusual. And the reason for that is if you know urban search and rescue, there are periodically times where we'd have this big horn, and the horn would blow if they wanted everyone to stop and be as completely still as possible. And the reason for that is because we had search dogs and we had listening devices, and we thought we heard somebody. And so they would want the entire pile to freeze, literally. And we would be frozen 10, 15 minutes until they gave an all clear, and then we can go back into our what we were doing. And in my case, I was actively searching. And then and that's when I wound up taking a lot of my photos. So I didn't really take a lot of photos of action because, I was there to work. I wasn't there to take photos. But once in a while, when we got the all clear, I would take a photo once again, just kind of try to get a panorama of what we were dealing with. In this particular photo, I took this is, I don't know if you can see my cursor. This is Dave Brooks, and Dave, our Lieutenant Dave. Dave and Dave, and we kind of stayed together as like a crew, a family. We didn't want to get separated. So you dug with your colleagues. You worked the pile with your colleagues rather. And I took a photo, and then I looked and I noticed that Dave was very upset. And so I handed my disposable camera to somebody else. I'm like, hey, can you just take a couple of shots? Be mindful. I only have 36 photos. Take a couple of shots while I check on Dave. And one of the shots, he actually got me checking up on Dave. And I walked up to him, how's everything going, Dave? I just do a check-in. And he was very upset. We hadn't seen, we'd been there for, over a day, and we hadn't recovered anybody that was alive. And I'll spare you the details of the people we did recover, but it was pretty gruesome. And so that it takes its toll, really in situ while you're there on the scene. Why are there so many 9/11 related health problems is, these two photos that I took are really self-explanatory. So, the photo on the left, once again, multiple occupational health and safety violations. You see first responders, two firefighters here with varying forms of PPE, personal protective equipment. This firefighter doesn't even have his bunker gear, his helmet is in hand. Clearly, there's debris and stuff like that, the potential for injury. No, neither of them are wearing masks. Beyond that, if you look here, guys are storing food, and there's snacks on the bumper. There's water up there, there's Pepsi, there's other food. If you scroll to the right, there's my good friend Oswaldo Robles, his wife, well, his girlfriend then, but now his wife Celicia's in the background, and then my friend Dimitri. And I've known Dimitri since I was 18 years old. That was my very first partner. Um, and and they're eating and resting in this dust, right? We lived in this dust for days. Um, and they're delivering food to us, right? So they're encouraging us to eat because they know we're not going to leave. So, Salvation Army, the city, the government, they're just dropping off food. And you see Ozzy there just eating in this dust. So very little reason um, so you can appreciate rather why there's so many, so much Crohn's disease, why there's so many bowel and gut disease, colon cancer. The list is long, because we were just living and eating and sleeping. Literally, I have other photos, people just sleeping where they were in the dust. Um, Now, this is not to really place blame on anyone particularly, but it's widely reported that the EPA, which is the Environmental Agency Protection, the Environmental Protection Agency, the federal government agency that is tasked with understanding, risk and hazards in the environment, and promulgating the risk and risk mitigation to the public. They did air sampling relatively quickly, so kudos to them. But they found erroneously that the cleanup site was not a real toxic exposure. And that was widely criticized thereafter. Christine Todd Whitman she was the governor of New Jersey previously, and then she became the EPA administrator under President Bush, the second Bush, and she's been widely criticized for making that declaration. And this is probably the best picture I can show you. You can see the spire in the back. This is what we were breathing in, my friends. PM 2.5, even smaller than that, fumes, pulverized, very micropulverized concrete, silica, from glass, uh, building materials, Stinger missiles, apparently, that the CIA had in one of the buildings. It's like, you name it, it was in there. And so this is what we were breathing in. Very fine dust. It's hard to describe. Um, and there was, once again, the respiratory protection issues are very plain. You can see this responder on the left. He has a mask, and they gave us masks, and they dropped off boxes of masks. But once the EPA gave the all clear, they said, you don't have to wear it if you don't want to. And so they would have their mask over here, not covering the nose. This is another responder. Some people have them. They give different masks out. And if you know occupational health and safety, you have to be fit tested. These are what we call form-fitting masks. They're respirators. They're not, dust masks like you would get at Home Depot. And so OSHA requires that you be fit tested for these type of masks. And there was no fit testing. There was no fit testing basically means that you try different sizes of masks. They put a hood on you. They make sure that you can't smell anything. And, that you can, they switch it up. The other thing is if you have significant facial hair, you can't wear a form-fitting mask. They'll have to give you something else like a hood or something like that. Now none of those occupational health and safety standards were applied here. And so you even had the president at the time come down, no mask. And so later on, it got a little bit better with protection, but you can see on the right, once again, the trained eye will notice that, I'm circling with my cursor here, if you can see it. This individual is not wearing the mask properly. It's clearly not firm fitting because the loop that he's got, the strap is not tight, and the bottom strap isn't on, which, so basically this is a non-complete seal. Same thing with this gentleman. And so, the problem with respiratory protection on the disaster scene of this magnitude was availability. Con Ed dropped off some masks, the Port Authority dropped off some masks. They were, it's kind of like pick your mask depending on your personal preference. And that's how occupational health and safety works. You have to be fit tested for it. And then you have to know how to use it. And the last thing is, you have to perceive that there's a risk, an inhalation risk, right? And so if you don't perceive that there's a risk, then you're not going to wear the mask. And that risk perception was diminished, not eliminated, but diminished with the EPA's erroneous statement that the air was relatively clean. And then, I'll be honest with you, even if you had the availability, even if you were fit tested, even if you knew how to use masks, and even if you knew the risk, quite honestly, you're not going to be able to do what we did on 9/11, 12, 13, and 14 with a mask on for, 16 hours, right? You remember COVID. Any of you guys tried to, jog or run on the treadmill or exercise or just run through the airport because you're running late with that mask on? And, as soon as that mask gets sweaty, it starts collapsing on your face. You can't breathe. Well, remember, September 11th, it was a beautiful day, warm, kind of like a day like this, maybe a little warmer, and you really sweat through that mask pretty quickly. You couldn't breathe in it. And so there was a comfort issue. And there was no enforcement. So generally, when you have occupational health and safety, you have people who were there on the scene to enforce that, and we had none of that on that day. Now, conventional, I'm giving you a little peer into emergency response now. Conventionally, in a fire ground or SWAT team operation, or you name it, hazardous material spill, you have an incident commander who's that one individual, she or he is running the whole disaster operation. And they have command level positions underneath them. But the most important command level position is a safety officer. And that person's not getting involved in rescue or doing it, fighting fires or chasing down the bad guys. Their job is just to go around and make sure that the fire ground or the disaster site is safe. And that's how it's mapped out on paper. In reality, this often doesn't happen, or it doesn't happen initially. And so I love showing this photo. This is, once again, another great example, varying types of PPE or lack thereof. But what you can't see is on the other side of this pile, there are first responders working the other side of this pile, right? This is the remains of the South Tower. To orient you, for anyone who's been to New York, this is the Deutsche Bank building, which had to be demolished. And on the corner here, if I had another, if it was bigger, you would see there's a Burger King. It's still, the Burger King is still there, by the way. And so just to give you orientation, this is kind of like the most southern exposure of Ground Zero. A few days after I took this photo, and I went back to my normal operation, this facade of the Deutsche Bank building, which weighed over about 2 tons, wound up falling and crashing where responders were working a few days earlier. Fortunately, no one was there. And so, we're talking about one, two, three, four, five, almost 5 stories worth of cladding that crashed down. And so just to give you an idea of the enormity of the lack of the disaster and the lack of occupational health and safety. And safety remains an issue for responders. We affectionately call ourselves the Blue Canaries because, you could send first responders in and they'll figure out whether people are dying or not. The canary in the coal mine, we call up to that because we wear blue. This is actually a photo I took. Fast forward 10 years later. I'm running forensics for the city. I'm in charge of the medical examiner's office. And I show up at a disaster scene, and the first thing I do is I take a photo. At this particular site, this was casino bus that crashed, overturned, killing almost 20 people instantaneously. Responders are there. They're climbing on top of the bus. The bus isn't properly what we call cribbed or stabilized. There's diesel fuel spilling out all over. These guys are just sloshing through diesel fuel. And once again, I look at this and I'm like, 10 years later, we still haven't gotten it right. Part of the problem is the uniqueness and challenge, the uniqueness that disasters pose. They're really, first responders are used to going to, 1, 2 patient scenes, right? Car crash is probably your worst case scenario. Maybe it's what we call an MCI, multi-casualty incident. But disasters cover large geographic areas. So you go there, it's the enormity of the situation. I'll just juxtapose 9/11 versus another disaster that I went to that Sasha mentioned. 9/11 covered, blocks, many, many blocks of New York City. So you go there and it's surreal. It's almost unreal. It's like a movie set, right? And then I go to Sandy Hook, and it's a human disaster, right? The school, the classrooms are still what they were before the shooting. It's a smaller area. And so still probably it was more traumatic for me, Sandy Hook, than 9/11, because 9/11 almost was unreal and Sandy Hook was very, very real. And so they can involve intense or multiple hazards. You're just not used to seeing an entire skyscraper collapse, let alone two, right? And then the subsequent smaller skyscrapers collapsing. So it really is of a scale that first responders aren't used to. And, as the complexity of the disaster increases, so does the risk by first responders because the normal rules of engagement just kind of go out the window. So what's being done? So in the immediate aftermath of 9/11, someone very forward-leaning said we need to set up a health registry. And I'm glad they did that. I'm enrolled in that health registry. I remember maybe about a year or two later getting a phone call saying, you were at 9/11, we need to, bring you into this program. And so now, every year since I think 2004, I go back to New York and I do a whole full day of battery of tests, pulmonary function tests, blood work, um, X-rays, you name it. They also add, questionnaires. I usually sit in front of the computer for about 45 minutes to an hour answering hundreds of questions about my mental health, my emotional health, my physical health, my sexual health, things that you would think that they wouldn't want to ask until you see the outputs of this. And so that's all part of, it started off as a World Trade Center medical monitoring group. They compiled, um, and they allowed us as a cohort to be studied, and they make that data available freely. So it's not, if you're a researcher in France and you want to get access to 9/11 responder data, you can sign an MOU, Memorandum of Understanding, and you can get that data. And so this annual report, this is actually the last annual report that was done under the work group, compiled hundreds of peer-reviewed studies, um, once again, and looked at uh, the cohort of 9/11 responders versus non-9/11 responders. What it found overwhelmingly is that many of us have immense physical hurdles to overcome, mental health hurdles, including higher rates of PTSD, alcoholism, drug abuse. Um, and this research was really seminal and led to probably the cornerstone 9/11 policy, which was the James Zadroga Act. James Zadroga was a first responder who passed away in 9/11 from 9/11 related injuries. What that did was it took up until then, there was some federal funding, a lot of funding for the long-term surveillance by state and city. But if you understand these registries, long-term surveillance is very expensive. It's very resource draining. And so this really places it firmly in the federal government's realm. It's authorization that happens through Congress now under the James Zadroga Act. The state and localities don't have to foot the bill for that, and it provides for long-term funding. It also that's why this was the last year this report was done. It transferred over to NIOSH, the responsibility of tracking health. And then after that, you started seeing it being picked up by the federal government. So when you get this PowerPoint, it'll be minus the photos, but you'll have if you hover over the report, you just click on it, and I embedded the link in there for you. And so what did they find? Some, lessons learned. They also found that a lot of us were working too long at the site. And I saw that from my own eyes. Guys didn't want to go home. Their brothers were there. In fact, I treated one firefighter. He basically went berserk on the pile. People were trying to pull him off. When they were able to pull him off, he wasn't wearing gloves. He was digging barehanded, and he had severed multiple fingers, but he was still going. And so that was an immediate traumatic response. But many of these are delayed. One thing I want to add, I've been diagnosed with PTSD. And I'm able to cope with it through various mechanisms. One of the mechanisms is giving this presentation every year. In a different context, I give this to my intelligence, homeland security, and terrorism students on the anniversary or the week of the anniversary of 9/11, and it helps me kind of cope with what I saw that day and the trauma thereafter. But one of the things that I think is you should understand is that first responders face immense psychological issues, some of the highest rates of suicide and drug and alcohol abuse by profession or amongst first responders, particularly law enforcement, and that kind of goes hand in hand with the military as well. Uh, First responders get what I like to call micro traumatization over the course of their career, and it just builds up. It doesn't really go away. You see a child that suffered a traumatic injury. You see, these horrific things over the course of your career, and they just kind of builds up. And I see, I can't unsee the things I've saw over a 20-year career, and so you just have to have some built up resilience or have a system that provides resilience. Um, I want to get to some of the more juicy stuff. Let's see, check the time. I'm doing good. Um, Once again, I won't belabor you with some of the reports, but if you the last MMWR was put out in 2021. It showed many more first responders were enrolling, and they expanded first responders to other responders that had came in a mutual aid capacity to help New York City. So initially we just started off with like firefighters, police officers, and then it got expanded. It also certified World Trade Center related conditions, provided what we call a definition, a case definition for what a World Trade Center related disease was. And so we saw, cancer rates very high, mental health, digestive issues. I have multiple friends who have Crohn's disease, things of that nature. Um, I think the interesting thing is that this is what, the healthy worker effect. We talk about this in my class, right? Um, these are like strapping, bodybuilding, very healthy, generally individuals. And so it's interesting to see how quickly cancer started onset. Normally, the latency periods for most cancers, if you use mesothelioma as a great example, it's about 20, 25 years. We started seeing cancers in about 8 or 10 years. But these individuals are relatively resilient. They live a healthy lifestyle. And so it really distorts, I think, the burden of cancer, even though the burden of cancer is so much more higher than non 9/11 responders. But they're also aging. And so now you have the additional burdens, comorbidities with age, as well as confounders from a research standpoint. This is a video I've left in here. You guys can click on that. It's really quick. I think it's about 5 or 6 minute video. A lot of research has been done on how to protect first responders. If this is something you're interested in, RAND teamed up with CDC, came up with a great series of reports that I leaned on heavily when I was writing my papers in college. And then, I think it's worth having a discussion about who are emergency responders. I think 9/11 helped us expand that definition. On the right, you have what we call a CERT team, as community emergency response teams. That was really pushed about 2 decades ago by FEMA to train local community people, regular folks, not government workers, on how to respond to communities, to disasters in the community. It's an acknowledgement that disasters may isolate communities, and the first responder is your neighbor, a school teacher, the mechanic down the block. Those are the first responders. And if community is isolated because of disaster or large scale conflagration, you can't wait for trained first responders in that period that you may be waiting for, minutes to hours. People could die. And so we really started thinking about expansion of that definition of what is emergency responder. Construction workers. We had a lot of construction workers, as I showed earlier on in the presentation, and many of them are experiencing also 9/11 related health issues, but they don't have the protections that first responders do in terms of getting screened, and healthcare and insurance if they pass away. And we've seen that just to kind of expand your scope and pull back the aperture here. It's not just 9/11. 9/11 can be also considered an environmental disaster, clearly, large scale contamination to the environment. But we also see that with oil spills. This is a Deepwater Horizon. A lot of research. Fortunately, they also set up a health registry for the Deepwater Horizon, but they did a lot of research and found that these individuals were also getting very, very sick from the caustic, fumes they were inhaling, benzenes and xylenes and all those things you would find with petrochemicals. And so as a guiding principle, anyone who's going into this field of, emergency occupational health and safety should understand that responders tend to ignore their own safety. They're geared to respond. You don't want the firefighter who's coming to save you in your house to stop at the door and say, should I go in here? Right? That's not what we train them in the academy. We train them to go, 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 right? Think about school shootings, right? We've criticized those police officers who stood by the door waiting for a SWAT team while kids were getting killed. We train them to go, go, go. Even if you have a handgun and they have a rifle and they have body armor, you go, go, go. And that creates occupational hazards that are as a byproduct of that. Once again, this is just for your knowledge, because I'm getting a little short on time and there's one or two more things I want to get to. But the Deepwater Horizon oil spill explosion and subsequent oil spills is a really great case study on environmental contamination and worker health and safety. And many of these people were volunteers. I've included some literature if you're interested in here. You can kind of look at some of the more seminal studies. One of the ones I don't know if I put in here was there's actually, I didn't put it in here, but if you email me, maybe I'll put it in for the final one if you email me if you're interested. One of the ones I really found was interesting when I teach environmental disaster classes. I talk about this study that looked at the children of 9/11 responders as a cohort. They also looked at children of responders in Israel and their levels of alcohol, drug abuse, mental health issues compared to similar children. And they found a huge increase in risk for those children whose parents were exposed to these hazards. And so this has a societal thing. Like when a first responder dies, the implication is that trauma doesn't necessarily die with the first responder. It can be passed on. And that just makes sense from a social sciences standpoint, from any type of, if you've done any addiction studies, alcoholism is passed on, drug abuse can be passed on, mental health can be passed on. You can imagine all the symptomology from a 9/11 responder, from, violent outbursts to all the PTSD symptoms being passed on to their children and the children having issues. So someone's going to say before he asks the question, what about OSHA, right? OSHA plays a role in a limited way in emergency response. They set standards, they help provide training and outreach and education, they establish partnerships. This is on their radar. But at the end of the day, OSHA does not enforce, by and large, disaster sites. And the reason why is very simple. They'll have a team to go out there, but OSHA, if you understand Occupational Safety and Health Act, the exclusion for that is the public sector workers. Public sector workers do not fall under OSHA. And so states may decide to adopt their own OSHA. Most states have a state occupational health and safety with rules that are similar to that of OSHA, but OSHA cannot come down on a state like New York City and say, you didn't protect your 9/11 responders, you're getting fined. OSHA is only there to really do enforcement on the private sector side, and they do a great job on that, right? Building sites, they'll investigate, all these things. Like if a building was being constructed and it caught on fire and workers died or collapsed or things like that, if there was an occupational accident that, people suffered at a private site, they would do that. But government related work, which is where first responders are on the realm of the public sector. OSHA, I can't call up OSHA and like, hey, my job is exposing me to risk as a firefighter. they're going to say contact your state OSHA or your city OSHA. And so there is an issue there. And so there's also a role in public health, broadly speaking, right? In, before the event, identifying hazards like I've talked about earlier, conducting training and exercises, creating that next, we understand there's a gap in public health professionals going into occupational health and safety with a sub concentration of disaster response. I was the only one in my program then, and since I've left my program, nobody has gone through with that specialty, right? And so you really have to be like a first, you have to be really vested in this to come at it from this perspective. And most first responders, unfortunately, don't go on to get doctor degrees or master's degrees because the job is really what they enjoy doing. And it's not that I don't enjoy doing the job. I miss it every day. It's a calling, but many people start and then retire from that. And that's when they're retired, they don't want to go back to school and do anything. So early on in the disaster, environmental monitoring for any type of airborne contaminants, or it's important. That was done. Unfortunately, it wasn't done optimally by the EPA. And then, I think we make a pretty good case of post-disaster taking care. We know that first responders are going to be traumatized. We understand that to be the case, and making sure that there are systems in place to protect them and their mental health, I think, is critically important. And so I promised to give you 15 minutes for question and answer. I'm a New Yorker, so I talk fast, so I apologize. But I did want to cover a lot of information. You'll get this presentation minus my personal photos, obviously. But if there's any questions, I'm happy to take them now if you want to moderate that, Sasha.
Yeah, of course. Thank you so much, Dr. Harvin. That was an incredible lecture. Yeah, now is the time that we're going to open the floor up to questions. As usual, we're going to have my colleagues from the HAPI program ask questions first, and then we can move on to the general public if we have some extra time. I know that your class starts at 1 p.m., so we can make sure that we ask questions as quickly as possible. I think we have a question from Taruni first in the chat. She said, "Thank you so much, Dr. Harvin. After 9/11, there was a push for long-term physical and mental health monitoring and policy changes. Though this is very different within the healthcare sector, I had a question about the COVID-19 pandemic. The attitudes towards occupational exposure and long-term health were far more split. What lessons from an occupational health perspective do you think could have been adopted better in the past few years? Is this an issue of how we view risks in different fields?"
Yeah, I think that's a great juxtaposition between September 11th, 9/11, and COVID. And I was not a practitioner during COVID, but I oversaw field responders during that time. And one of this, we placed our first responders in a really disproportionately more risky environment during COVID. We had resource constraints in terms of PPE. I know many first responders that were using the same N95 mask over the course of many days. You saw that with healthcare staff. They were given, a Ziploc bag with, 2 or 3 N95s and told make this work for, 6 shifts or 5 shifts, whatever they were working. We overworked them. I don't know anybody that was allowed to have vacation. Many people were forced overtime. It's something in first responder world we call mandate. You're mandated to work. And so placing a huge physical and psychological burden on them. I remember, you remember the YouTube videos and the Facebook videos of first responders and medical workers just bawling because they just emotionally couldn't do it. And so we didn't have the proper resources. I think we threw them right into the fire. We expect them to kind of like, suck it up. And in terms of that, I just want to, I don't want to go too far off topic, but there's a quick anecdote that I want to share with you. So I mentioned I was down at ground zero for a few days. Then I went back to my station and I was working the midnights. And I logged on, and the dispatcher said, go to the citywide frequency. So I went to the citywide frequency, and I reported in my unit, I think 35 X-ray, and I said 35 X-ray and citywide, and they said, 35 X-ray respond to World Trade Center, location, blah, 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 and, establish, with the command there. And all I remember is yelling at the dispatcher on the radio, cursing at the dispatcher, saying, "I'm not going back." And I repeatedly told the dispatcher I'm not going back. And that's the next thing I remember. I was being held down by some of my colleagues because I literally had trashed the entire garage. I blanked out and just started throwing things around. My lieutenant came in, calmed me down, and put somebody else in my place. So I think it was Robles went there. And what do you think he did? He didn't send me home because we didn't have any people. So he put me on an ambulance to work Brooklyn North, which is Crown Heights, Brownsville, East New York, and do shootings and stabbings for 12 hours, right? That was my kind of like bringing me down. Never was offered any type of assistance, and you were just expected to suck it up and pull your weight. And we see this so many times with emergency services. We see this with military folks, especially hard burden on women who feel like they have to keep up with men, and they have to prove themselves. And it takes a real impact on their psychological and emotional health. So I just wanted to add that.
All right, and then we also have a question from Dr. Few Berman in the chat. There are lots of data on mine workers and other workers not being willing to use respirators or even masks. That's not a regulatory issue. How do you suggest addressing that?
Some of it's culture. I think that I'll tell you, police officers and firefighters don't wear masks. Even during COVID, they didn't like to wear them. Medical first responders, like paramedics like myself, who happen to work for FDNY, we were used to wearing masks. We were exposed to TB, we were exposed to people who had all types of germs. And so wearing a mask was not unusual to us. Plus, we were fit tested. Even so, I would love to see an analysis between lung cancers within first responders. Maybe that's out there. And my hypothesis would be that, medical first responders fare better because we're just so much more used to we wear mask in training. Your first day in the emergency room, they send you into an isolation room. You got to put a mask and gown on and stuff. Whereas the firefighters and police officers aren't that way.
Right,
So,
but it's mainly talking about like respirators in these bad conditions. Like they're uncomfortable and people won't wear them.
yeah. So the problem is that besides the availability, they are uncomfortable and people aren't going to wear them. And the only way to get around that is a more expensive alternative, which is a PAPR, which is powered air purifying respirators, kind of like those CDC hoods, which you can wear for hours. I've done that in my hazmat CBRN trainings for hours and hours. It just constantly blows air. Those are very expensive, and they're actually not practical when you're doing a lot of bending over and moving around. They're great in the lab, but they're not great for when it's going to get fogged up. You're digging people out of the rubble. It's hot. And so I don't know if we can make these type of scenes safety from a respiratory standpoint.
Awesome. And then, June, would you like to ask your question next?
Yeah, thank you so much for your talk. It was super informative and incredible. I was wondering if you think that separate regulatory agencies should be like created for disaster relief and other like epidemiological efforts, or if you think that existing occupational agencies can sort of bridge the gaps that you were talking about.
I'm not a big government person. I actually think that, just my own personal opinion. I think we rely on government way too much, and they fail us often. I think this is more of an industry issue. I think public health doesn't really talk about first responder occupational health and safety because they leave that for the first responders. It's kind of like the peanut butter and the chocolate. Like if you put them together, you get a Reese's cup. But no one's really effectively put this together in this way post 9/11. I thought that they would. You've had a lot of research, but if you go to any firehouse, police station, and ask them about their occupational health and safety, they're probably going to give you some, Xerox copy of something from like the 80s or 90s, right? So the other thing is, I think organizations like OSHA do a great job in the private sector. I understand the complications with extending OSHA protections to the public sector employees, government employees, but it's something to be considered, I think. there's a bifurcation there. It's you know, federalism, right? So states can really oversee what they want to do. Some states do voluntarily adopt OSHA regulations for for their government workers, and some have their kind of different variations. So 50 states, 50 different solutions. I don't know the answer from a policy standpoint, but I think awareness that this is an issue is important. I'll be honest with you, and I don't say this too often. If I had known on September 11th what I know now in terms of how people, I mean, we've had more first responders die after 9/11 than on 9/11. If I had known that, I would have not gone. If I knew now, if I knew then what I know now. And that's not what you want from your first responders, right? You don't want them to not go into the industry because it's not only safe, but you're not going to be taken care of. Um, so just my personal opinion.
Thank you, Dr. Harvin. And then we also have a question from Giro in the chat. Thank you so much, Dr. Harvin, for this great presentation, including the pictures. Given the current political gridlock surrounding gun violence, is there any realistic path for such long-term federally funded monitoring and mental health care to be established? Alternatively, would it require state-level innovation instead?
Yeah, I think a state by state solution is important because gun violence is really a state by state issue, particularly the access of guns and what they do. I will tell you that if you dig into the BLS, the Bureau of Labor Statistics, I've done a couple of graduate papers on this. First responders are not only just the riskiest from the environmental standpoint in terms of occupations, but also in terms of physical violence. First responders are assaulted. We've seen many incidents where, just I think the last year you had, ambushes set. Remember, the fire was set to draw on first responders, and they were shot at. And so this is just a risky job. I've been attacked on the job. I know people who've been stabbed and shot on the job. I know first responders who've been killed just doing their job on the roadside and things of that nature. So once again, it is, I think, a forgotten community in terms of occupational health and safety. And, I think the public thinks broadly that we just pay these men and women to go into, they know what they signed up for, right? You hear this all the time, right? That they just go into this job. But, we want to go home, right? We want to come back the next day to serve you. And so that is an issue. But gun violence is really a state by state issue. And I think it's part of a bigger discussion in terms of the violence that people are exposed to.
Thank you. And it doesn't look like any of my other colleagues have any questions, so we can move on to the general questions. Mr. Goen, would you like to unmute yourself and ask your question?
Sure, thank you. More of a comment for the doctor. Thank you so much for your presentation. So I was a responder to the Pentagon on 9/11. And just to add to your perspective, when we went in to the Pentagon, they really weren't prepared to refill the air in our cylinders. And so we were advised to go in as far as we could without our gear affixed to our faces, and in a pitch black environment, right? And through the course of that day, myself and my crew, we did that a couple of times. And because, it was hard. So you would hand a half full cylinder off to somebody when you came out, which is, completely, not what you want. Your comment about the cardboard camera from CVS totally resonated with me. I have a couple of them, my own, with some pictures. And what we're seeing with the Pentagon folks is we have a high incidence of PTSD, a lot of lung disease, a lot of glioblastoma. And strangely enough, we're seeing a lot of people, police and fire, that are showing up with Parkinson's disease and diagnosed very young, late 40s, early 50s. So thank you for what you do and for your presentation. I appreciate it, man. Thanks.
Yeah, I appreciate you and the, I talk about the New York experience, but I know the brothers and sisters were fighting the fight in Shanksville as well as the Pentagon. So we're one community, and hopefully you guys have the same type of support that I get at FIDNY. But I will tell you, just as a side note, Michael, I go to headquarters every year. I was just there a couple of weeks ago for my physical, and I always see a poster or see someone that said, "Oh, do you know this person passed? Or do you know this person's sick?" And it really weighs on you. It really just weighs on you because there's also this kind of expectation, like next year when the doctor reads my chest X-ray, what is he or she going to say, right?
Right,
Like, and so that's not a good way to live life. You just
right.
really have to find your way around that.
True, true. Thank you so much. Appreciate you.
So Donell, you have a class that starts in 2 minutes, I think. So,
I got a few more. I can take a few more, Adam. They haven't started coming in yet.
okay, well, let me say thank you, and I'll leave it up to the moderator and you to decide when to quit. So thanks again.
Thank you.
Yeah, I think we have one more question. I think Miss Rosenberg requested to raise her hand. If you want to unmute yourself, you can ask a question now.
Thank you, Dr. Harvin. Excellent, excellent presentation. God bless all of you and your team and those who perished and those who are ill, and God bless all of you. As a reporter, I cover the deep water and the Sandy Hook, so I know a little bit about these things. And I have two questions for you. One is, what can we do in the way of prevention? Especially the gun, well, you mentioned the gun violence, but prevention of these major disasters. And the other question is, who goes into this line of work, the first responder? What motivates them? What do they hope to get out of it? Thanks again.
Yeah, it'd be easy for me, and uh, maybe Michael can share his experience, but it'd be easy for me to kind of overly simplify it and say adrenaline junkies. The adrenaline may get you onto the job, but it doesn't keep you on the job, right? Because eventually you come, resistant to adrenaline. It really is about doing something that's bigger than you. And I know that sounds corny, but it's the same reason why people go into most public service, public health. I have friends from Harvard Humanitarian Initiative that could literally be making 7, 8 figures, but they're working as volunteers in an Ebola crisis for 5 or 6 months on a stipend, right? On a daily stipend. So it really is having a sense of contributing to mankind in a way that's bigger than you. Um, and what keeps you in the job is camaraderie. Those few times that you're able to make a difference, you feel like you're chipping away at the misery that the human condition can pose to people. You see people on their worst day every day, and it takes a toll on you. But once in a while, there's a glimmer because you're able to, deliver a baby or save a life or just make someone smile, right? And so once again, I hate to sound corny, but that really is what it is. I mean, I got into it because I was a lifeguard, and one day I saw some, paramedics and firefighters come in. I had to rescue someone from the pool, and they came in and took over and they revived the person. And it was for me, it was cathartic. I was like, that's what I want to do, right? Like, so. I don't know if that answered your question. There was a second part to that.
Well, just overall prevention of
Yeah,
the
yeah, yeah.
virus and the gun and the ecology, just prevention in general.
Yeah, I mean, I don't think anyone thought about a plane crashing into a building, right? But I think there's analogies that we can take away from 9/11 when I think about the more a natural disaster, a building collapse from an earthquake. That is something. And once again, I think really integrating occupational health and safety from a public health standpoint into the emergency services, I think is really, really key. It's bridging the academia with the practice. And I see, when I read a lot of these reports, they don't really, I hate to say this, they don't try to talk they talk over their audience, which is first responders, as opposed to talk to them, and they don't really operationally bridge the research with the practice. And so I don't know any fire chief or lieutenant or captains and sitting around reading some of the research that I'm going to share that I share with you. And so how do we make this sticky? How do we make this consumable by the audience that really needs to have it? And I see a lot of these folks are just doing this, especially some of the stuff that coming out of Mount Sinai in New York. It really is just getting their publications so they can get their tenure or their PhD. And, I think it's a little sad because I don't think the stuff is consumable.
Thank you.
Okay, I think that's all the questions that we have today, unless anyone wants to unmute very quickly. But I think we've gotten all of our questions answered. So thank you so much, Dr. Harvin, for such an incredible lecture and so efficiently answering these questions. And I also want to say thank you on behalf of me and my colleagues who see you twice a week. Everything that you did as a first responder in 9/11, we really appreciate hearing your perspective on all of this. So I think that's everything from me. Thank you guys so much for attending this week's HAPI seminar.
Thank you, and I'll see you guys in a few hours in class.